Welcome to Sky Women. I'm your host, Dr. Carolyn Moyers, a wife, mom, and board-certified OBGYN. This is a place to educate, empower, and inspire. Join us each week as we share the power of women's stories. Real women, real stories, real inspiration. Put on your stretchy pants. Let's get going. Welcome, Sky Women. Welcome back to another episode of Sky Women Podcast. I'm your host, Dr. Carolyn Moyers, and we are so lucky to have with us today a psychiatrist, Dr. Priscilla Hidalgo, who goes by Dr. H. Most of her patients call her. She's a psychiatrist in private practice, serving patients in North Carolina and Florida, and she helps patients who struggle with stress, anxiety, and depression, and who are just really feeling overwhelmed in their busy lives. And she helps these patients to find balance and enjoy life a little bit more and feel a little bit stressed. Welcome, Dr. H.
Thank you so much. So excited to be here.
We are thrilled to have you because I do a little bit of gynepsychiatry. A lot of times when patients come to see the gynecologist, there's a lot to unravel. And a lot of what we experience as a woman impacts our mood. And there's there's this biopsychosocial component of what we experience as a woman, whether it's body image, our thoughts about sex, our vulvar pain or pelvic pain, right? And then we go through this mysterious perimenopause and menopause. And oh, hell, we all need a psychiatrist.
That is completely true. One way to think about it is that in the same way, let's say if you're stressed out, you get headaches or your stomach hurts or you have diarrhea and stuff like that, and you go to see a neurologist, gastroenterologist, your vagina and your vulva can also be stressed. Especially when they see the gynecologist.
Yes. Hyper or overactive pelvic floor. Yes, absolutely. 100%. People who clench their teeth or clench their jaws tend to have a hypertonic pelvic floor and then have pelvic pain. So yeah, it's all interconnected, right? Yeah. And I feel like we have done several sessions or several episodes on postpartum depression and mood disorders around pregnancy and early motherhood. But as my practice focuses more and more on perimenopause and menopause, that's what I really was excited to chat with you about today, because we know that the list of perimenopause, menopausal symptoms is vast and like no organ system goes untouched. We have difficulty sleeping, insomnia, changes in periods, depression, sadness, mood swings, aching joints, hot flashes, night sweats, trouble concentrating, low energy, more frequent UTIs, right? It's all across the board. These are happening because of our ever-changing hormones in this period. And when we look at those who have a history of depression, depressive symptoms can actually worsen during this time, this transition, and the transition through menopause. So remember, ladies, that menopause is defined as 12 months without a cycle. Perimenopause are those years around menopause, and you can have symptoms for a decade, a whole decade. So there's mixed evidence as to whether depression disorders are more common during the menopause transition relative to premenopause. But if you have a history of depression, there's definitely a high risk of recurrence during this time frame. Are you seeing that a lot with your patients?
For sure. And especially if women have a history of premenstrual dysphoric disorder or PMDD, they also tend to experience worsening symptoms as they're going through the transition. And I think it makes sense because what we're talking about is the fluctuations in the sex hormones and how that impacts your mental health, but also your physical health, as you were saying earlier. And I think we have more evidence for depression like perimenopause. And we know that women report more symptoms of depression at that time than postmenopausal. And I think postmenopausal is definitely an area that needs to be researched a little bit more. But I think it makes sense that it's kind of hard to research when, especially you're having, a lot of studies have different definitions of what is the perimenopausal period? Not everybody hits it at the same age and all that. But one thing that we can all agree on is that things change so much for women later in life. And, if we talk about, let's say, risk factors, we're not only talking about the fluctuations in sex hormones, but we're also talking about the role changes. Life changes for you. You're taking care of older parents now, kids are older, You will also, work changes. And, I have to tell my patients that, women are in impossible situations at times. Like, you're supposed to excel at work, excel at home. And at the end of the day, you still should feel energetic and glamorous so you can have sex with your partner. And it's just not possible to do it all that. Imagine adding to all those pressures symptoms of perimenopause. It's crazy.
Yeah. Truly. Yeah. I was thinking, like you may have teenagers during this time, you may be sending them off to college, and, parenting a teen is not for the faint of heart. I mean,
True.
Yes. And then on the aging parent and all the things, and then you're likely, leading a team at work, and you're going through all these changes, and like you have just your brain stops. You can't follow that thought in the middle of your meeting, right? Or your presentation. It's like incredibly embarrassing, or you're hot flashing to strip off layers, I mean, there's so many components to it. And quite frankly, I know menopausal, perimenopausal women do not feel supported in the workplace. And so there's a lot of components to this to unpack. But when we think about the depressive symptoms and, the mood changes and the mood swings and all that, we know that estrogen therapy has some efficacy in managing depression in midlife, because obviously if we improve hot flashes and night sweats and the insomnia, then we're getting better sleep. And we all know when we sleep, things are better between our ears, right? But we may also need some medication for the mood. But what I find is that a lot of patients have just been handed SSRIs, have just been handed antidepressants by multiple doctors, and are like, oh, just try this. And nobody wants to put them on hormone therapy. And that's another story for another day, because there's just inadequate training in hormone therapy. But what are your top tips? Because it does take a lot of different approaches. We may need hormone therapy, we may need psychotherapy, we may need a psychiatrist and medication.
I would say the first thing, if I have a patient who has already a history of depression and already a history of PMDD or premenstrual dysphoric disorder, number one, we need to get you an appointment with a gynecologist, because there's no medicine that is going to be able to compete with all those symptoms. I don't have an antidepressant that can make you happy when you have vaginal dryness, when you can't have sex because it's so uncomfortable, when you have just brain fog all the time, or you're having these hot flashes. That being said, I know that antidepressants can help to some degree with the vasomotor symptoms like hot flashes and night sweats, but it's only part of the solution. And so getting the gynecologist involved is very, very important. And I work closely with the gynecologists that my patients see, as well as their therapists, because I think this is a group effort, a team effort, essentially, to take care of this. And the other thing that I think about is that if somebody has been on an antidepressant before and that worked well for them, and let's say they're not taking it anymore and they're going through the transition, experiencing symptoms of depression, I would say most likely than not, I would restart that antidepressant that I already know works and the patient is able to tolerate. Now, treating depression with antidepressants can also be tricky, because of course we want to avoid things that are going to worsen, sex drive, or, the ability to achieve orgasm, or weight, don't cause weight gain stuff. And a lot of antidepressants cause that, unfortunately. So we also kind of have to learn to balance the side effects or possible risks of the medication with other things that we're trying to treat, like the depression. And I think that in addition to medications, I also work with my patients a lot on changing the mindset and the way that we think about menopause and going through the transition, because I think we often feel discarded, like, okay, this is what's happening and I'm done. My vagina is all dried up. Everything is all dried up. Nothing else is going to get better, or like, I'm not good enough. I'm not glamorous enough. And part of that is the lack of estrogen, or like the fluctuations, I should say. So getting the gynecologist on board is number one. The other thing in changing the mindset is like how to reduce how critical we are of ourselves during this period of time. Because I think a lot of women, they're just, I want to be like I was when I was in my 20s. And I think they dismiss the I don't want to say like how great it is right now, because if you're going through menopause, it's not great, but
Yeah.
I mean, without treatment, but like you are dismissing everything that you have gained throughout the years and all the value that you have. And of course, I always recommend patients to connect with a therapist if they're not doing therapy with me, because we know that especially for vasomotor symptoms, perimenopause, therapy can be very helpful because we have to again change the way that we think about these symptoms, and you can train your body into how to deal with all this stuff that comes up many times all at once.
Yes. Yeah. And a lot of times it hasn't been talked about. And so, I mean, one of the common complaints that I hear is I just don't feel at home in my body anymore.
Mm-hmm.
Like I don't know what's going on,
Yeah.
and it hasn't been discussed really openly in society, which menopause is having a moment right now. I mean, we had an ad during Super Bowl. There's been at least 2 New York Times articles on menopause, and Oprah just had this fabulous special on perimenopause and menopause. So it's definitely having a moment. And I feel like the conversations are opening, but yes, understanding what's going on with your body is key. Now, you mentioned something that I want to go back to. You mentioned the antidepressants that can impact sexual desire. And so let's address that. And I want to ask, are you familiar with Addie, the little pink pill?
Yes, I am. Yes, I am. I don't use it very often, but yes.
What are your thoughts in regards to that? Because it acts on the central nervous system. And so, sometimes patients feel like that their mood is improved, that their sex drive is improved, and sometimes they even lose weight. They're sleeping better. So, I mean, thoughts on this?
Yeah, well, I would say whenever I have someone who complains of having low sex drive, of course, I go through the list of things that we need to rule out. And like I said, going to a gynecologist is paramount, because many times people can have like a chronic pelvic pain syndrome or something that actually is causing the low libido or the low interest in having sex, because you have something else that is actually causing it. We also have to make sure that we're, ruling out history of trauma. There's so many, other things that we have to kind of pay attention to. And once I do that, then we go through, okay, is it menopause? Are we looking at a depressive episode? What exactly is it that we are looking at from my standpoint? So before I start treating hyposexual disorders, so what I do is that I try to make sure that everything else is under better control, because the priority, as much as I always tell people, sex is part of a healthy life. I want you to enjoy sex. You also need to make sure that every time you're having sex, you're not having flashbacks from, a trauma event that you experienced. Or like you're so depressed that you just not only not have interest for sex, you just don't have interest for anything else. So we start there. The part where I also include the gynecologist is because I know sometimes you guys use like a little bit like low doses of testosterone also to kind of treat that. So I usually ask the patients to have a gynecological evaluation to make sure that it is appropriate for them to be on this kind of medication, make sure we're not missing something.
So before ever initiating Addie, you would say, see a gynecologist.
For sure.
And I think that's fair. So with your SSRIs, your SNRIs, or serotonin selective reuptake inhibitors, which ones are hardest on sexual desire, or have the most sexual desire?
I would say the SSRIs are pretty bad. Prozac or fluoxetine is one of the main ones. I mean, to the point that most of us psychiatrists, the way that we think about it is that you're likely going to develop low libido. Is very likely that that's going to happen. But so we also move to like SNRIs, like venlafaxine, desvenlafaxine, duloxetine. These medications are actually my favorite to use with women that are going through menopause. And it seems like they have much more robust response when it comes to like depression, the vasomotor symptoms of menopause. And sometimes once you actually stabilize the depression and let's say they're doing better, sometimes you need to add something to these medications to kind of counteract some of the side effects, whether that being like weight gain or sexual side effects. Like we were saying, bupropion is a completely different antidepressant that we usually added to a regular antidepressant like the fluoxetine or desvenlafaxine to try to see if we can counteract some of those side effects that may happen. One of the reasons why we also do this, because a lot of times when we reach higher doses of an antidepressant medication, we're able to get some benefit but we're not where we want to be. So we may add another antidepressant medication. And sometimes what we do is that we add something like that perhaps can counteract the sexual side effects from an SSRI or SNRI, and then move on to something that can maximize the treatment or optimize the treatment for depression. There are some antidepressants that have less likelihood of causing sexual side effects, like the bupropion I was saying. Mirtazapine is also kind of on a category of its own. That one also has a lower risk to cause sexual side effects. And there are newer ones like vilazodone that tends to also be a little bit better when it comes to that. But again, it really depends on, the choice of the antidepressant. It really depends on the patient, their history, and what they have been on in the past. And of course, if you add the hormone replacement therapy to all this, that is definitely going to help.
Yeah, absolutely. I find that a lot of times patients do come to me on an antidepressant because that's all that their internal medicine doctor, has provided for them, but they're still having the hot flushes and night sweats. And a lot of times if the vaginal dryness and the pain with sex is the worst part of their symptoms, I'll go ahead and put them on both systemic hormone replacement therapy and local vaginal estrogen. And it improves so much. And it's like so fun to see when they come in for their follow-up and are like, this is amazing. I can have comfortable sex again, but I feel like we could do better with the desire, right? Like I'm doing it hurt anymore, but I'm missing that desire piece. Right. And of course, sexual desire is probably for another episode, right? We could really all of it.
It's a whole conversation altogether.
Whole different conversation. But, when the relationship is good and there's no history of trauma and no other medical complications, et cetera, and Addyi is a good option for them, then I like to add that to allow them, to have a little more, relief. I mean, we also have Vyleesi. We have a couple of medications, a couple of things that we can do for low sexual desire if that is issue. So I want listeners to know that they do not need to be disheartened if they feel like that their antidepressants have caused a low sexual desire. There definitely is tinkering around that we could do with their medication or adding one of these medications if testosterone is right for them, if they're postmenopausal with a low sexual desire and their testosterone levels are low, that may be an adequate option. There's also the on-demand Vyleesi, which is a sub-Q injection that you can administer 45 minutes prior to going to be sexually active or planned sexual activity. And then you have the Addyi, which is a once nightly pill. So a lot of options for low sexual desire.
Yes. And I think that women, you're right. I'm glad that you'd say, don't worry, there's always an option because I think often, we chalk this up to, I'm just getting older.
This is just the way
what it is, which is, that's not a thing. I mean, you still should be in the same way that you're interested in doing other things. The interest might change, and the way that we think about sex might change, but we're still, sexual beings. We're social beings. So it is part of who we are as animals in this planet. And I love the fact that you just mentioned that and you said, don't just think of that there's nothing we can do, because there's always something we can do for sure.
I think that happens a lot. Patients either feel dismissed or they think that, whether it is with their antidepressants, whether it's with their hormone therapy or their birth control pill or whatever, they feel like it and it didn't work. So I'm done. There are so many options. You just have to have the right provider who will talk you through these and be willing to try these, and you be willing to, be compliant with the medication and see if it works.
But honestly, I think it's also a problem with us physicians, because many of us don't have the training, or the knowledge to have this discussion with patients. And many times like, I don't know anything about this, so let me ask you to do this. Go talk to that other person, and maybe that person can help you. And I think that we, as physicians in general, we should get better at asking these questions from our patients, just so that way, because a lot of patients don't want to talk about this, that they might not bring it up themselves, but asking them about this stuff can actually also normalize it for them.
Okay, so you bring up a really interesting point, because on my new patient intakes, I do a PHQ-9 for depression. and I do a 5 questionnaire for sexual desire on all of my new patients. And so I'm asking these questions. I don't know if everybody else is. And I didn't always, it's kind of been an evolution. So if you were talking to the gynecologist, or the primary care doctor, what would you hope that we would at least ask about, at least open the door?
Yeah, I wouldn't focus so much of how many times a week are you having sex, because I don't think that is as relevant as it is the woman's experience when it comes to sex. So I would ask about, are you interested in having sex? Are there times where you're not interested? Do you experience any pain when you are having sex? Most of the questions when I'm exploring sexual history, it's best when I just ask about them. So I don't put so many questions in an intake for myself, just because I have a different style when it comes to asking about it, because it's part of a whole other thing that I'm doing especially when we're looking into trauma and all that. But I would certainly ask about, what if you're experiencing any kind of discomfort when you are having sex, if you have interest in having sex, do you think that there's anything, that could be better? Also, and when it comes to having sex, and I would actually put a question of if there is a problem with any of these areas, where do you think that is coming from? Because that way, that also makes them think, about I didn't think about this, but I wonder how long this has been going on and why is this happening?
Right. I mean, and so part of the questionnaire I ask is, has your interest in sex changed? Does this bother you? Do you want to do something about it? And what do you think is contributing to it? Right. So is it partners' issues, whether it's erectile dysfunction or whatever, or their own health concerns, or if they've had pelvic surgery or other medications or chronic medical illness, right? So there's so many aspects to it. But it's just 5 general questions that you can kind of open the door to because if it's not bothersome to you, then we don't need to talk about it.
Well, and I think that the fact that you're asking about it honestly makes them think about this. Yeah. Because even if this was something that they were thinking about, patients, when it comes to things that may be uncomfortable for them to talk about, urinary incontinence, let's say, in women.
Yeah.
They're usually not
about a mood killer, right?
Exactly. Yeah. They're not going to say, oh yeah, I'm going to have sex where I'm always afraid of the smell, or that I'm having leaks or something like that. If we don't ask about it and normalize it and say, this is a normal complaint. I want you to tell me about this stuff. It's going to be very hard for patients to just bring it up themselves. And because it's uncomfortable for a lot of people to talk about this.
Sure. Absolutely. So I want to switch gears a little bit and chat about ADHD and diagnosis of ADHD in the adult female. Do you see this occurring or being diagnosed in perimenopause and menopause, or do they usually have the diagnosis already?
No, so it really depends. So I always like to think about what is a woman's life like, because, women are usually kind of overlooked, especially when they're kids, when it comes to a diagnosis of ADHD, especially if you're not, and this is in general, if you have the type of ADHD where you're not bouncing all over the place, where you're just quietly not paying attention to anything that is happening. If you're not disruptive, people are not really going to think that there is a problem. They just assume that either you're lazy or you're just not smart enough, whatever it is. So I think a lot of women grow up with that, oh no, I'm just lazy, or I'm just not smart enough. This is just something that I cannot do. And as they go through life and they experience different challenges, like for instance, in college, you have to initiate more and you have to be able to be more self-disciplined. They end up struggling a whole lot with that. And then after college, then it comes, when they're at work and having to shift their attention to different things that they have to do, and also at home and all that. Menopause and perimenopause is a very interesting stage, because menopause itself, the transition itself, is actually going to make your brain foggy. You're going to have problems with recall. You're going to have problems.
The MRIs of the brain from premenopause, perimenopause, menopause.
Say that again.
They've actually done imaging of the brain during these times. There are measurable changes.
Oh yeah, no, it changes so much. And I think that there are other, like I said, like we were talking about earlier, you have all these transitions happening in your life, not only in your body, but socially, culturally, and all that. So then, you have these women who are like completely, forgetful, and they are not able to sustain attention. And most of the time they say, oh no, it's just, I'm having perimenopause, and that's it. And then what ends up happening a lot of times is that even after you treat depression, you treat anxiety, my approach is always to make sure we stabilize psychiatric issues before we do a proper evaluation of ADHD, because inattention is sort of like fever. It tells you that something is wrong. We don't know what is causing it, essentially. So once everything else is treated, and let's say, you are on hormone replacement therapy, and let's say things for the most part are okay, definitely we need to do a dive in to make sure that we are not missing something. Now, when I say this, I'm talking about in patients that may not have severe executive dysfunction. Now, people that have ADHD and it is severe, even during menopause, is going to be worse. So they will have even more problems than usual. For instance, I had a patient once that was telling me, this is a question I always ask women. I was like, did you miss any exits? Did you? Because a lot of times you're driving and you miss an exit because you're completely distracted with something else. Yeah. So I ask about those things. And if you have a lot of issues with this, I would say, well, maybe we don't wait until all this stuff is resolved. Maybe we need to start treatment now to make sure that, we're setting you up for success.
Yeah. I mean, I could see how that would be really, really challenging when you're managing a household now, or you've added kids to the mix and you're busy with all the different aspects of life, perhaps managing a team at work, and you're trying to focus and get everything done. And that scatterbrain can really, create havoc.
For sure. And I always ask about what was it like when they were kids, because for a diagnosis of ADHD, you need to have symptoms when they're kids. Because I think a lot of women, one of the most common complaints I get is that I have ADHD, especially during the pandemic. Everybody had ADHD.
Oh yeah.
They couldn't focus, and that was very disruptive. And one of the main things is just like either my antidepressant was working fine and it's no longer working, or I was doing fine, and then now I'm feeling more depressed. I don't know where this depression really is coming from, or like, why is it that I'm having a harder time coping with things? And another big one is that one is like, I can't focus. My brain is distracted. And I had a patient that said, imagine this, you have like just 2 tabs open, but your internet is dial up. And it's just like always downloading, always uploading. There's nothing that is really happening. And I cannot explain it because I cannot get my thoughts to be as fast as I want them to be.
Yeah, 100%. So talk me through like your top tips. I know that we've talked about depressive symptoms and treatment options. And it sounds like medication plus therapy is definitely key, in addition to any hormone therapy that you might need. With ADHD, it's getting the proper diagnosis, evaluation, and treatment, right? But if we're talking about lifestyle, what would be your top tips for patients, in addition to being compliant with their medication and with their therapy?
That was going to be my number one, actually.
Okay.
After you're given medications, take them, because they have a problem. They don't work if you don't take them. So, that's an issue. I would say the basic stuff is paramount, like making sure that you're sleeping the best that you can. And that goes into what we were talking about also earlier, like making sure, even if you have to take medications to help you with sleep, you should go ahead and do those. Of course, making sure that you have a healthy diet and exercise is good. I don't think there's a lot of evidence that exercise actually helps with vasomotor symptoms of perimenopause, but it can be very helpful for mood and for anxiety. So I always tell patients we really need to incorporate this. Those things become easier, like maintaining a healthy diet, exercising, living a healthy lifestyle becomes easier if your depression is better, if you're not as anxious. So in the beginning, it may feel really hard to do those things. So I always tell patients, focus on just one thing that you can do today. And it can be very small. I'm talking about to the point of, I got out of bed. You got out of bed, you did what you were supposed to do today. Or like you
Yeah.
brushed your teeth today. Because I think we always think of like really big things to accomplish in one day. And then when we see that we are not able to do those, then we are, we're very critical of ourselves. The other things that can be very helpful is that we know that mindfulness meditation can also really change everything. And that is one of those things that can really help you get grounded and kind of collect yourself, especially if things become really overwhelming.
Yeah.
There are, alternative treatments that people try using, like over the counter stuff. Let's St. John's wort, let's say, things like that. But that stuff, it's not stuff that we actually recommend. We think that if you engage in a healthy lifestyle and you follow up your medical treatment, I think you're actually going to be in a better position to kind of go through all this. And last but not least, self-compassion. Like I was saying earlier, women are very self-critical. Yeah. And I think if we start shifting a little bit or reframing the way that we think about ourselves and we think about our lives, about going through the transition and all that, it's actually going to make that easier. We actually know that women that are more optimistic and are less self-critical, they actually have an easier time going through the transition. But that is easier said than done a lot of times. So we just kind of have to put in the work into it. And that you can do with, one thing that I always ask patients to do as a mini exercise is, if you were going through the same situation, would you say the same thing to your best friend? Most people would say, no, impossible. I would never talk to my best friend like that. I'm like, yeah. So why would you talk to yourself like that?
100%. 100%. We are our own worst mean girl. Mm-hmm. Yes. Yeah.
Yes. Yeah. It's amazing. It's truly amazing. And also try to find your tribe. Try to find the people that lift you up, the people that support you, the people that are not going to judge you. I know that it's not always easy to do, especially when you're adults. Making friends as adults is not as easy as it used to be when you're kids. Where you're just like, may I have your crayon? And it's like, oh, great, we're best friends for life now. So, but really having that social support, other group of women that you can talk to, and and I say women, not dismissing, having your partner or having friends of other sexes, but I think women are usually better equipped to understand other women because we go through some of the same things. And I think, only in our heads is when we have, this cape that we have to do everything and we're supposed to be Wonder Woman. And I think sometimes it takes someone else to tell you, hey, you don't have to do any of this. And also recognize that you're not okay and that you can get help.
You will ask for help. I think that's huge. I think that's huge. And you're the second person in the last week who I've had on the podcast who's brought up mindfulness and meditation. And it is absolutely a practice. There's a reason they call it practicing meditation, right? It's not easy, especially for type A's who are on. Like, I've implemented this into my life and I'm a big fan of Joe Dispenza. Are you familiar with him?
No, I'm not.
Okay. Phenomenal books. I've read one of his books so far and absolutely love implementing it into my life, but I'm not, up to 30 minutes of meditating a day by any means.
No.
If I can sit still for 5 minutes, we're good. Sometimes I do walking meditations, right? And envision that future version, how I want to show up in my day and my life, and I give myself grace. Like I lost it with my kids last night. Bedtime was just, it was a dumpster fire, and I lost it with my kids and I felt bad about that at the end of the day when I reflected, and so this morning I got up and it's a new day and I sat with my meditation and how do I want to show up today? And I can show up new every day.
Yeah, no, actually with meditation, it's so interesting that you mentioned like not being able to do 30 minutes because I've never been able to do, the most that I've done is 5 minutes. Yeah. And I remember when I started practicing it, I couldn't go beyond 30 seconds because I started going through the laundry list of things that I needed to do in the day or like the grocery list. And I would have to kind of pull myself back every single time. And for me, the way that I use meditation is that I use it especially when I am overwhelmed. So what I trained myself to do was that whenever I would feel overwhelmed or I'm feeling like I have so much in my head, that's my cue that I need to slow down and that I need to do just like a 1 minute, something that can kind of just make me put everything together. But it is so powerful. Like however anybody wants to do it, it is very powerful on its own. But we know that when people do it regularly, it definitely changes the way that we respond to things, and it increases that threshold. So that way you don't really lose it as quickly, and you are less anxious and less stressed.
Yeah, absolutely. Well, we've covered a lot today, and I would love to have you back because there's so many other topics that I'm sure listeners are going to have questions about. Our mental health is health. It's so incredibly important that we address this. And I think that oftentimes with women, we just kind of push it aside. We keep pushing through. And once you get treatment, I think that it really opens your eyes, like you didn't know how much you were suffering, and you don't have to suffer alone.
True. That is completely true. Yeah, I think that's one of the reasons why I am interested in women's health, because I think we pay attention, like I was saying earlier, if you have a headache and all this, but we assume that all the systems are separate from each other. Right. And we don't think of it. This is the whole body, like being able to take care of yourself, being able to take a mental health day, being able to say, no, I'm not going to go to this place just because I want to rest or I don't feel like it.
Yeah.
And I know that is not always comfortable to say no.
Mm-hmm. It's not, but no is a complete sentence, ladies.
Exactly.
All right. This has been an absolute pleasure, Dr. H. Thank you so much for joining us. Until next week, be well.
All right, Sky community, thank you for listening to another episode. This episode was sponsored by Sky Women's Health. As a reminder, we're in the Dallas-Fort Worth area, and we help relieve back pain and pelvic pain in pregnancy and beyond. If you are pregnant and having pain and you feel like you have no reliable way to relieve it, look us up at skywomenshealth.com, request an appointment, and we'll call to get you scheduled. As a board-certified OBGYN with a Neuromusculoskeletal Medicine fellowship, I help you realign with hands-on drug-free treatment and relieve pain on the spot without medication. We'll help you maintain these results through your pregnancy and postpartum period. Every pregnant person deserves this, and we are so excited to serve you. You can find us on our website, as mentioned, or on social at Sky Women's Health, or you can call the office at 817-915-9803. That's it for today. Until next week, be well.